start off, we're going to kind of zoom in on what we're talking about with the thoracic spine. A thoracic spine, 12 vertebral bodies, and they originate at T1 at the top. And if you were to look at, and I'll take some of these layers off here. If you were to look at the vertebral bodies from top to bottom, they're smaller at the top, and the vertebral bodies, or the main bony units, get larger as towards the bottom, and they start to look more like the large lumbar vertebral bodies. And this makes sense because the lower down you get, the more weight bearing is occurring. In between the vertebral bodies, as we zoom in, and let me take off the nerve also here. If we zoom in to this is a vertebral body, you see a space between the vertebral body above and below. This space is made up of the intervertebral disc, and we'll talk, I know, at length about the intervertebral disc and its significance. The vertebral bodies of the thoracic spine are a little different in some ways than the cervical and the lumbar. One of the primary ways it's different is you look at the back of the vertebral body. So I'm looking at your person's back, and this is the center part, the tip of the spinous process. You see where this vertebrae, the green one, interacts with the white one below. There's what's called the facet joint, and there's a joint on either side. So there's two facet joints going down and two facet joints going up. They're shaped in a different plane than the lumbar spine. If you look at the lumbar, these are the facet joints for the lumbar spine, and they're at 90-degree angles, really, to what the facet joints of the thoracic spine are. And so this leads to one of the characteristics of the thoracic spine is that it's surprisingly able to rotate pretty well, but it's not very, it's fairly stiff in flexion and extension. The other aspect about the thoracic spine region is that, of course, there's ribs going on there, and the ribs connect through these partial facet joints. And you can see here we have the green vertebral body, and the top of the green one interfaces with the head of the rib on the bottom half of it, and the white vertebral body above intersects with the top of the rib. So each rib connects to two vertebral bodies and kind of goes over the space where the disc lay. Finally, if you zoom in around, I'm going to try and dodge the ribs here. You can see that there is an intervertebral foramen, and the foramen is made up of this green arch, and you see the rib at the bottom, and the facet joint in the back, and the disc in the front. And I'm going to add the nerve here, and you'll see where the nerve comes through. Here you see the costochondral nerve coming out of the intervertebral foramen and running along the inferior surface of the rib. So at each level, you have a nerve that exits the foramen and goes out along the rib at the undersurface of each rib. And that can explain would explain the dermatomal pattern of pathology that affects the nerve there. I'm adding a little more nerve here. This shows branches from the nerve root coming back to form the sympathetic chain that runs along the thoracic vertebral bodies. And that also can explain some of the pathology that you see with thoracic conditions. So I think that's the main aspect. There's one other thing I wanted to just show you briefly, which is the musculature of the back. And so one of the differential diagnoses that I see all the time in clinical practice is a patient comes in and they've got pain between the shoulder blades or on the side of the back somewhere. And the question is this a pulled muscle or a strained muscle? Well, just to get some idea of the complexity of this, I'm going to throw some muscles on here. So we've got from each level, you've got muscles that run here from the rib to the vertebral bodies above, 2 or 3 above and 2 or 3 below. And that's just the first layer. Then we'll keep going. Then you've got more paraspinal muscles. Then you've got longitissimus muscles that run all the way up and down the back. Then we add another layer of those, then side muscles that go across. Then this is the latissimus dorsi coming around the top. And then we get to the rhomboid muscles that connect between the borders of the scapula. Most of the muscles in the back are what we call postural muscles, and they're not muscles that we sort of actively contract. They do their thing without us asking them to. And so they're sort of, I think of them as sort of reflexic, and they're there to protect the spinal cord at all costs. And so you'll get muscle spasms with the muscles doing their thing to help stabilize the spine. And then finally, we'll just kind of zoom down here. This is looking from the top, and this just shows we're at the cervical spine here, but when you get to the so when you look down at the spinal cord, let's just bring it down here, you can see that the nerve roots generate off of the spinal cord. The spinal cord obviously coming down from the brain and heading down to the lower parts of the spine. The thoracic spine is interesting because there's not much room for the spinal cord, unlike lumbar area and the cervical area where there's generally more room. It's pretty tight in the lumbar canal, and there's not, and so there are, with pathology in the thoracic spine, it is more possible, or made perhaps more likely, for what's called myelopathy or problems involving the spinal cord. One final thing to show, and we'll get Jeff to give you the detailed go through here. There's one other aspect of the thoracic spine that's interesting, and if you look at it, the thoracic spine and the ribs form a solid unit down to T12. And then when you get right below T12 at L1, it doesn't have really that same support of the ribs. And so this change in the biomechanics of the thoracic spine to the lumbar spine is the reason that the vast majority of spinal trauma involves the T12 L1 junction. Burst fractures, fall from heights, that type of thing. Many, I think it's estimated 75% of those types of injuries result in problems where where between T12 and T1, or extended a little bit, T10 to L2. This area where the thoracic spine characteristics changes to the lumbar spine characteristics is where mechanical failure typically happens. Jeff, I don't want to eat up any more time, so I'm going to kick it right back to you. So thank you.
Wow. I mean, I'm always impressed with this model of the spine and how you can spin it and turn it and put the layers on. And in particular, I think we have some of the folks here today who have watched us talk about the cervical and lumbar spine, and probably what is striking when you consider the thoracic spine is some of the incredible differences, right? One is the ribs and the fact that you have this huge rib cage. And the second is you have these really significant layers of muscles, and you have a scapula that's, sitting between muscle layers. You have a trapezius that's spanning between the neck and into the thoracic area. And there is a real potential with that sympathetic chain that you talked about, which is, I think, a very fascinating thing to pause on. I think in orthopedics, we really put a lot of emphasis and weight on the somatic system. And I just want to talk about that. The somatic system is that which we can think about, right? And we can move. I can move my finger. I can move my arm. it's a direct connection to the cerebral cortex, and it's volitional, meaning I'm controlling it. There's a whole separate nervous system, which is the autonomic nervous system, which is controlling your visceral organs, things that are working and acting despite our knowledge, right? Our heart, our lungs, our liver, our kidneys, our gallbladder, our intestines. And these tissues are organized and innervated by the autonomic nervous system, including the sympathetic system and the parasympathetic system. And you can view those as having kind of competing forces on what our tissues are doing. But why does it matter? Well, look, the systems are not working in complete and utter separate natures. There's these connections, and you saw on Dr. Crabb's model how there's a connection from the sympathetic chain into the nerve root that will feed into the thoracic cord. And it's during that convergence, right, from the nerve root that's coming out of the spine, and then the little branches that are going in from the sympathetic chain. This confluence creates a blend of your autonomic system and your somatic system. And I think that this is why we have patients with pain patterns or severe pain problems that we're not fully understanding, because they're being amplified by the autonomic system. And we're still learning about that as providers. You'll probably see in here where we say we can't fully understand why the pain is as it is, or what's happening, what are all the elements. And maybe over time we'll see greater knowledge that we move forward on it as it relates to the sympathetic chain. But thank you, Ian, for showing those areas. I'm going to take a moment here and share my screen. Now you should see a screen. Okay, yep. Thank you very much. Thanks for your patience. So we did talk about what makes the thoracic spine different. And we do know that it's kind of the part between the areas that we're commonly looking at with workers' comp issues, which are cervical and lumbar. And I think as such, it's a little bit of a no man's land, and it's a little bit of an area of conflict and controversy, because it includes pains that can come from below or come from above, and they are overlapping, and they can be very confusing. And like the other areas of the spine, and as pointed out by Dr. Crabb, the areas include bones and discs and ligaments and nerves. And we divide them into various columns, as noted in this drawing. And what it looks like on a plain film is it's harder to see than it is a cervical region or a lumbar region, because there's overlap. In this case, you can see the overlapping ribs coming at angles. You can see the impact of the lungs and even the heart shadow. On the right screen is the front view of the spine, and I'm outlining the heart shadow. You can see the vertebral bodies stacking up. You can see an area which are called the pedicles. There's two in each bone. And then there's the midline spinous processes. What you can't see are discs. Discs don't show up on plain x-rays. You can see the ribs. You can see how the lateral view is really hard to differentiate. There's so much overlapping. So it's common that we're not getting major clues from the lateral image. And this is just a study trying to show, or what we were just talking about, the various overlapping views and what we can see. It gets a little cleaner if we go to a CAT scan, and the CAT scan view will show the bones really well, but you can't see the discs. And so this CAT scan is better for if you're looking at the bony qualities. And this one is showing you a vertebral body, and it's showing you a cross section. And what you can see is how the vertebral bone is actually made up. It's made up of these internal columns of supporting bone. And as such, a vertebral body is very strong unless it becomes weakened by virtue of osteoporosis or metabolic processes within the vertebral body that weaken a lot of these cross connecting bone strands. So we mentioned before that the thoracic region is different because it's made up of ribs, and it also has these internal organs, the heart and lungs. And I just thought I would show you how it all comes together. The thoracic spine is kind of buried underneath the heart. It's buried underneath the aorta, and you can see the different lung fields here. The rib cage does make a difference in how stiff the spine is because it surrounds the entire thoracic area. And this is a CT axial image. The discs, again, are the areas where you have the spacers, and they're made of cartilage in between the vertebrae, and they do allow motion to occur, but there is much restricted motion in the thoracic spine occurring as a result of the ribs primarily. This is an MRI view showing what you can see. You can now see the discs, which look like these rectangular spacers. When we're young, discs on a T2 weighted MRI, which this is an example of a T2 weighted MRI, are white, and this indicates that they're hydrated. So discs are in youth, very hydrated, full of water, and this allows them to work better. This is the thoracic cord that's coming down in the spinal column just behind the vertebral bodies. The end of the cord is at the T12L1 level. It doesn't just stop, but it's breaking into branches called the cauda equina, which in Latin means the horse's tail. So as a horse's tail will start as a firm cord and then branch into multiple branches, that's the appearance here in this region of the lower thoracic spine. Where you see white is cerebral spinal fluid. Again, water is white on the T2 image, and cerebral spinal fluid is produced in the brain. Your brain floats on fluid, as well as your entire thoracic cord and the nerves of the cauda equina in the lumbar spine.
Quick question, Jeff.
Yes, sir.
Yeah, so we've had a couple of lumbar burst fractures, L1, T12 burst fractures, and some of the related questions have been some of the sequelae neurologically can occur from these.
Yes.
So maybe you could just touch on, a fair percentage. I think it's about a quarter of burst fractures in that level will have some long-term neurologic sequela from this injury.
Yeah, so the point you had made earlier, again, to re-emphasize it, is the area where you're going to accumulate stress during a trauma is the area where there's an area of transition. So the thoracic region through here is very rigid, supported by ribs. But as we get into the lower thoracic area and start to get into the lumbar area, we lose those ribs. So it becomes a biomechanical junctional location where a lot of stress and strain will occur during a traumatic event. That will cause a pressure on the vertebral bodies, and I showed some images showing you how they're made up of very strong bone that's bridging as little bridges inside there. But if they're weakened by trauma, then they can be broken. And as the name implies, the burst fracture, the bone is burst open. And you can see if that occurs in the lower thoracic spine, you're at the proximity of the thoracic cord, and in a burst fashion, the bones become retropulsed and come out and lodge here in the spinal canal, impinging upon the end of the cord. This leads to the high incidence of neurological change associated with burst fractures. What you can also see on this MRI are the interspinous ligaments, which are the connecting bands between the spinous processes above and below. And frequently in these kinds of injuries, these are torn at the same time as the fracture, the burst fracture, with pressure is occurring in the front part of the spine. So it's a true, what we call 3-column injury, with a bursting component injuring the vertebral body and a tensile or stretching component of the ligaments being disrupted in the backside of the spine, leading to a very unstable scenario with neurological compression. So that hopefully that looks at what you were taking a peek at in terms of your question, Ian.
Well, yeah, I was going to ask you, I guess, look, what I wanted you to bring up was the neurologic sequela obviously is is going to affect, can cause paralysis, right? But I wanted you to just mention the GI effects of fractures there, the autonomic effects that are sometimes present, urinary and GI.
Absolutely. Yeah, the end of your cord is the cell bodies for a lot of your functions as they relate to bowel and bladder. And those would be disrupted by having the cord compressed at that location. So yeah, no, you're
Yeah.
showing an example of a burst
Yeah.
fracture. This is at L2, I think. So it's lumbar 2, and you can see this is a good example because it's showing how the vertebral body is just smushed down, and then there's a retropulsion of the backside of the vertebral body, and it really comes out and clogs the spinal canal. This would be at what would be called the cauda equina level, so it could produce some changes, but the nerves are more resilient at this level than they are just a few levels above.
Okay.
So
Good.
yeah,
Good.
that's a good example. All righty, thank you. And we took a look on that model that Dr. Crabb showed, and this is an MRI scan showing you can get a view of the neuroforamen with the nerves exiting out underneath the pedicles, and you can kind of get a good view on an MRI that way. The ligaments, again, are these kind of tension bands that exist on the backside of the spine, and there's a ligament that is called the supraspinous ligament that runs along the top parts of the spinous processes, and then there are these interspinous ligaments that run between the spinous processes, and then closer to the facet joints we have capsular ligaments, and these are important because if these are injured, now I found this diagram helpful because just like this crane showing if you look at the function of these ligaments, they're like these guide wires back here. They're under tension. If you put a weight on the end of this crane, the weight bears down on the front side of the spine, and you can think of the weight bearing through the vertebral bodies, but tension is being brought or delivered through the ligaments on the back side of the spine. So if you injure the bones, that's up front, and that's a compressive force usually. And then, excuse me, if you injure the ligaments, you injure injure this tension band back here. Picture if I climbed up there and cut these wires, the whole crane would fall forward. I wanted to look at a couple of the conditions that affect the thoracic spine in general. And obviously our workers are going to have some of these conditions. They include bone conditions, and that includes metabolic bone conditions. If we live in northern climates, we're not seeing the sun as often, and so we have a higher incidence of having low vitamin D. Vitamin D, if you look at this, it looks like a busy slide, but it looks like, from drinking milk or getting sun, you can make vitamin D. It's also made by going from your liver to your kidney, and it helps you to absorb calcium in your diet. If you don't have a good amount of calcium in your diet, or you're not absorbing it, your bones will be weaker. And so I think a fair number of people have low vitamin D, and they can develop these kinds of changes in the vertebrae where they're less strong. A lot of these connections that we had looked at the microarchitectural level of the vertebral bodies are changed or altered, and it leads to it makes it easier for these to fracture. They don't need the same kinds of excessive loads of a car accident and they can occur at an easier level. Likewise, we can have, like we can in the cervical region and lumbar regions, we can have disc conditions and problems that relate to wear and tear of discs and even disc herniations. We've talked to this point before that in the cervical spine and lumbar spine, when MRIs are done of asymptomatic people, it is frequently seen that there are disc herniations. Now, they may not be symptomatic, so you need the history to understand and the physical exam to understand if a finding on an MRI is relevant or part of the clinical equation. But this is an MRI scan showing you how the MRI is really the best study to look at the discs, and you can see how this one is protruding and the impact that it has on the cord. The other levels, you can see disc degeneration with loss of disc height. You see disc desiccation, which means that there's less water in these discs and they're darker in terms of shape, in terms of color. And then their shape, they're lost in terms of their height, and you get these kinds of changes. This is common. And then you can get ligament conditions where
Hey,
the
Jeff,
ligaments. Yes, sir.
before we go on, can we go back to that for a second?
Yes.
I have some questions for you about thoracic discs. And so you've been a spine surgeon for a lot of years, I think, 30 some years.
Yeah, about 30 years. Yeah.
How many times have you operated on an acute thoracic disc? Decompressed it.
I would say that it's no more than one hand.
Yeah. So in 30 years, you maybe have done four or five
four or five
decompressions
cases.
for pure discs, not a tumor or something, but just for a disc. Yeah.
Yes,
So
they're extremely rare. And so I mentioned that we can find them on MRI and they're not symptomatic or they're not really part of the clinical equation, but sometimes they are. But this is rare, and I think that's the point you want to bring out, is that they're rarely clinically significant and they're rarely going to be something that is going to see surgery as an indication.
okay, and here's a question without a point. Are thoracic disc herniations more likely to be myelopathic, or do they present? I mean, I presume they would present with with rib pain, with radiating pain on the rib, but are they more likely to cause myelopathy or some type of spinal cord problem, or not really? They're the same as cervical and lumbar discs.
Yeah, if it's a large thoracic disc herniation that's compressing the cord, what we might see is myelopathy, which is a change within the function of the cord that leads to spasticity. So clinically, we're seeing hyperreflexia, spastic type gait. We might see associated weakness, but it's really the myelopathy, which is the cord-related changes that we see on clinical examination that are the major clues that we're dealing with a cord level problem, either cervical or thoracic. But yes.
And then I had one other just sort of observation as I was thinking about this. I see so many cases where, the diagnosis is degenerative spondylosis of the cervical spine and or lumbar spine, but we don't really talk about diffuse spondylosis of the thoracic spine. I mean, we see it as a finding on an MRI or an X-ray, but as a clinical problem, my question to you is, I mean, is it just because it doesn't move as much that the spondylosis seems to be a non-clinically relevant event, or do I just not see those patients?
I think it's the biomechanics. I think that the thoracic spine is being supported by the ribs and having less overall mobility, is not experiencing the same degree of mechanical stress or strain as the cervical region or the lumbar region on a
So
mechanical basis. And so
people
they
tolerate that
tolerate.
arthritis better.
Yeah.
Okay, good. I'll let you
They
continue.
seem to yeah, thank you. Those are great questions. I appreciate those. Thank you.
We actually have another question from the attendants. Tracy's asking, can you comment on the findings of Scmorl's node? I hope I'm saying that right.
Yeah,
Schmorl's
Scmorl's node. That's a great question too. I don't think I have an example. A Scmorl's node, I'm going to show an MRI here on this screen, but I'm not going to be able to show you a Scmorl's node, but let me describe it. A Scmorl's node is an indentation of the disc into the top part or bottom part of a vertebral body. And that's because sometimes these little areas along the end plate are weaker, and a little kind of bow of disc will go up into the end plate. It's rare that we see this as an acute issue or an issue that we can find much relevance to. It's more of a anecdotal finding, meaning we see it, but we don't think it's usually much in the way of clinical import. I don't think we can reliably say that it's a source of pain. I guess a handful of times, again, maybe 5 times, I've seen an MRI which will show a Scmorl's node, an indentation of disc into the top of an vertebral body end plate, and there will be a associated inflammation around that area. And we might say, well, maybe that's a semi-acute Scmorl's node. Maybe that just happened. But we really have a dickens of a time saying that that's the site of pain, and or that was reasonably caused by a certain activity. You're going to see us hedging. We just don't know. What do you think on this question of Scmorl's node, Ian?
Yeah, I generally have assumed it was just an incidental finding
Yeah.
and not related to trauma. So yeah, I ignore Schmorl's nodes as just an anatomic finding, not pathologic.
Yeah, they're kind of like hemangiomas or other
Yeah.
non-specific findings that populate a report, but don't lead to us to have a strong conclusion. Unless, of course, the rare case is a Schmorl's node with some edema around it. Is it an acute issue? Did it just recently happen? Normally, you don't see
Don't
them.
see that.
No. That's a good question. Hopefully I answered that to the.
Yeah.
Okay.
Thank you. We do have another question that just came in. It says, can you speak on the pros, cons, need for vertebroplasty in the thoracic spine?
We got a case,
Vertebroplasty?
I think, that's going to address that a little bit, right?
Okay.
Yeah. So vertebroplasty. I think I do have a case that will show some of this. I don't have. Let me. That's a great question, and let me see if I can move. Go ahead and so here's something called DISH, and you're probably going to see this in reports from time to time. Diffuse idiopathic skeletal hyperostosis. You might see ankylosing spondylitis. This involves ossification, calcification of normal ligamentous structures or tissues, including the discs, as well as those interspinous ligaments. This is an X-ray example of someone with ankylosing spondylitis, which you can see how it looks like a bamboo spine. If you follow your eye along here, you see a continuous bony rim that's just climbing up the entire thoracic area. Typically, you'll see these people will have a forward bent spine as well. We call that kyphosis, and they'd be very, very stiff. The problem is with this condition is if you have a minor injury, it's very easy to crack the entire spine through and through because it's brittle and it's no longer working as a segmented unit, meaning each vertebral body is now connected. So you have like a long candy cane and it cracks really easily with a minor trauma. Just another view showing what ankylosing spondylitis look at this kind of flowing ossification over the lower lumbar area. And if you try to find the sacroiliac joints, you can't see them. They basically close up as a result of ossification occurring across the SI joints. So keep an eye out for people like this. In the extreme way, they'll have these kind of obvious deformities where their spine will become very kyphotic and they're very stiff, called chin on chest deformity. They're looking at the ground. Most of the people we see won't have this degree of deformity that can get to this level, but you can have the findings of ankylosing spondylitis without the substantial deformity. And again, these people are at higher risk for fractures or injuries with lower grade events or traumas. You know, when we take a look at a vertebrae and we say sometimes there's broader patterns of ossification. Again, this is a CAT scan showing this, and this would be called diffuse idiopathic skeletal hyperostosis. You can compare it to the spine that doesn't have it on the right side of the screen, and you can see how the spine being tied up. And that's what really is, I think, unique in the thoracic area. It really gets a lot of this kind of process of ankylosing condition, where bone is lapping up. This is in the sacroiliac joint, lumbar spine, and this is kind of what we see down here. But then through the thoracic area, you see these large knuckles of diffuse idiopathic skeletal hyperostosis and big, large knuckles, again, making these segments of the spine very, very stiff, very, very rigid, and more susceptible to minor injury events, being cracked across, again, being brittle. The question was about fractures in kyphoplasty or vertebroplasty. I wanted to show this case. This is a case that sometimes we'll see in the thoracic area. This was this person's x-ray beforehand. This is the chest x-ray that I had showed before. You see the heart shadow and all the ribs and lungs, diaphragm of the below the lungs, collarbones, upper arms. And you can see kind of the scapulas here on the corners. And what's happened, and this is a side view, and there was a fairly minor injury where the person fell in the bathroom and fell against the wall in the toilet. And what you see on this is, wow, there's these clear rib fractures, multiple rib fractures. This is unusual. Now you can't really see the thoracic area clearly, again, because of the overlapping heart shadow and the aorta shadow. You can see how now the abdominal contents are kind of full of air and kind of swollen. In other words, the trauma here has created a kind of cascade. And if you look at now the same side view of the chest X-ray, you see how there's a noticeable change here through the upper thoracic area. These vertebrae have been compressed into wedge shapes as opposed to squares, and this is a substantial kyphosis. If you get a CAT scan, which will more clearly delineate the injury to these vertebrae, you can see how they are wedged down, and you can see there's a small portion of the backside of the vertebral bodies that are retropulsed into the spinal canal. This person was neurologically intact and had a lot of thoracic, upper level thoracic pain between the shoulder blades. And this is a front view showing the extent of the injury, and another front view. If we go through what's called the axial views in sequence, we'll really see the kinds of injuries that can occur, fracture through the transverse process, through the vertebral body, small retropulsion at the rib articulation, comminution, which means multiple fragments. The space for the canal seems reasonable enough. The bone did jut backwards, but didn't occlude the canal, so there was no neurological deficit. Broke the ribs. You can see these rib fractures here. And what you can see with this case is fairly minor, trauma falling from ground level height, hitting hard against a toilet and a sink, fracturing ribs. And this is maybe an extreme example of what can happen in a thoracic area that wouldn't be expected, and it occurs as a result of the this person had pre-existing osteoporosis and weaker bone. Now, going back, if I go back to this level and I say, well, what about these bones? Would these, if there was pain as a result of compression fractures, would these be amenable to a technique called vertebroplasty or kyphoplasty? Vertebroplasty being the injection of cement alone into the vertebrae, and the kyphoplasty procedure being a procedure where you put a balloon into the vertebral body to expand the balloon, trying to reshape the vertebrae, and then you have cement going in. So this shows that technique of kyphoplasty through the needle, a balloon is placed, the balloon is inflated, and it will expand both in an upward direction and downward direction, the shape of the vertebrae, and leave basically a little cavity within that vertebrae through which then that same needle, liquefied cement, is then inserted into the bone. Now, it is a good technique. It's an interesting technique because surgeons, we do believe in it, but it gets kind of mixed press because it depends on which article you look at. There have been articles that took kind of all comers with compression fractures and put them through the procedure and said it didn't really have a substantial difference. I think what you have to do is target the use of the procedure. It is not one that is going to be used in every vertebral fracture. In this case, it's not going to be used. The bones are too broken and there's retropulsion. It'd be dangerous to apply cement in some of these cases because it could leak into the canal and there's already a substantial deformity. It's better in the lower or part of the thoracic vertebrae. It's better where there's not retropulsion or severe deformity. And it's better if for a few weeks non-operative care has failed, meaning trying to brace, trying to give it time. I would recommend always a conservative approach to these fractures initially, and then if there's a severe ongoing pain that's recalcitrant to the conservative effort after a few weeks, there's a small pocket of people that I think would be amenable and actually good candidates for those kinds of procedures. They call them vertebral augmenting procedures, either vertebroplasty or kyphoplasty. Any comments or additional comments on that kind of technique as it relates to the thoracic spine?
Yeah, I'm not even as positive as you are for kyphoplasty. Again, for the older population, typically female with bad osteoporosis that has multiple thoracic fractures, the data is pretty clear that if you wait a few months, they heal just fine without having the kyphoplasty. And I'm not sure that you gain much in terms of protecting ongoing physical collapse by doing the kyphoplasty. So
yeah, where I tended to do them is here's an example. Like, I'll get a call that there's a person in the hospital unable to get out of bed because of a fracture, the level of pain, and they had tried a brace and they had tried medication. They were getting side effects from medication, and the pain was local to the area of fracture on percussion, and the person was so miserable and unable to get up and get going.
Right.
I think it's a reasonable case in that case, but you're right. The average person who comes in and says, well, I just had a compression fracture, I think they're going to get over that. The real advocates of kyphoplasty really emphasize this issue of sagittal deformity, meaning, the degree with which there's a kyphosis. And that they really advocate, well, you get the balloon in there, you jack up the vertebral bone, that reshapes it a bit, takes it out of the kink, the kyphosis, the biomechanics will change.
Right.
I see their point. Are you better to be straighter than bent? Yeah, right. I get it, but it doesn't really equate, right? I mean, we all see people with partial bent backs that are doing fine, and we say, well, maybe we're getting carried away with this concept of kyphosis, but yeah, okay. I think like most procedures, if people have heard me before, I think it's try a conservative, approach, but sometimes it's of value. Okay, good. I don't have any other slides to show. I think I went through the deck, and then any other questions on the issues relating to thoracic spine?
Well, yes, I do. So,
yes.
And we briefly talked about this yesterday, I think, which is the most common thing I see where the thoracic spine comes up, and it's the laborer, or it's any person that comes in with pain just next to the medial border of the scapula, right over T6 or T5, and it hurts right there like a hot poker. And they get seen first by someone that does a trigger point injection. Then they get sent to a shoulder guy that checks them out for scapulothoracic bursitis. Then they see a PA who orders them a thoracic MRI, and it shows a little blip of a disc, and no one ever looks at their neck, which has end-stage spondylosis and referred pain. Well, I'm setting you up for that one, but to me, that's the differential. Muscular pain in the back, scapular thoracic pain. Is it cervical referred pain, or is it some primary thoracic pain, God forbid, a disc? And maybe the last one would be herpes zoster.
I love your case that you're raising, because it's probably the most familiar to all the people listening who have familiarity with working with workers' cases and workers' injuries. It is a quandary, right? Because the persons can really bellyache and complain and find it really limiting, and the surgeon's usually nonplussed by it. Says, well, it was probably just pulled a muscle maybe near your scapula, rhomboids or levator scapula. Maybe it's your trapezius. And as you pointed out, it goes on a wild goose chase sometimes, right? Start with a little bit of time rest and anti-inflam, start with a injection, go to a myofascial massage person, get a chiropractor to try to align the spine, then you get an MRI, and then you're in a bigger bag of worms because there's some bulging discs. And boy, I tell you what, in these kinds of cases where it's nebulous, everyone wants to grab a hold of something. So it's like, oh, we got an MRI. There's a disc.
Right.
Well, the disc is unlikely the linchpin here. I understand you want to grab a hold of something, but it really isn't it. So I feel for these cases. So what do I do on this guy? He comes in and he goes, I was working. I tell him, look, this is going to get better. This is a self-limited issue. It doesn't require much in the way of rest or activity modification, maybe a few days, and some anti-inflammatory local ice, and then a gradual functional return. And really, but anyone who's listening to this will say, well, that's nice, but then what about the guy who keeps complaining and won't get back, and then gets in a vicious, he's got the pain from hell that no one seems to be able to localize until they get an MRI showing a disc, and that's not it. Welcome to the world of quandary. I'd like to sit here to tell everyone today I've got an approach for it.
Not to, I gave you an impossible question, obviously, but I guess my thought to you is for me, pain in that region is cervical until proven otherwise. In a person, say, over 50, right? But if you're presenting with new onset pain and not like a week or two, but pain that's lasted, say, for a few months, that's not getting better. For me, I'm thinking cervical referred pain, and I ask them about bifocals and neck position and all that other stuff, and maybe get some x-rays. Would
That's
you
a good
agree
point.
with that? Or
Yes. So the neck does radiate south into the thoracic area. Usually it will give you some clues because there will be some arm radiating symptoms as well. But sometimes it's purely lower neck, the cervical thoracic junction, going towards the scapula. And that is more likely than not cervical, radiating into the upper thoracic region. But again, I have to use the words more likely or probably, because unless it has an arm pain attached to it that's radiating a symptom that you can define to a radicular complaint, you're still scratching your head a lot and trying to piece the whole, opaque puzzle together.
Right.
We do
Oh, yeah.
have a situation that someone has asked. It says an injured worker with history of osteoporosis slips and falls, landing on their back. They had an ER visit with a CT scan. Cervical and thoracic spine was negative. The injured worker continued pain with the X-ray and MRI done 2 months later that showed a subacute fracture in T5. Can you explain the negative imaging initially, then the MRI showing a fracture?
Yeah. So this is a great question because there can be there can be fractures in the thoracic area with people with osteoporosis or ankylosing conditions, the ankylosing spondylitis and the dish, that are not detected on the first sets of images. And especially if they're plain films can miss them. CT is better than plain film for these kinds of very subtle fracture patterns. But sometimes what happens is what starts as a crack that can't be seen, over time, there's some absorption of the bone around the crack, becomes more visible, and then through mechanical pressure, it dents down the vertebrae a little bit more. Now we can see it more.
Yeah.
So there can be this delay in its appearance that can be really confusing.
Yeah, very analogous to the osteoporotic distal radius fracture, which you sometimes just can't see, and then 2-3 weeks later you start to see reabsorption and you can see the fracture sign. So
exactly.
yeah.
And that's the difference, right? Is I showed a case where someone fell pretty hard and it was obvious. But that's what I was trying to get at too, that there's patterns of people with osteoporosis and ankylosing conditions that can get not as obvious cracks or problems in the bone that to take some time to show up. And I think this is a good example that the person gave it as a case that's a case example on this.
Yeah. Yeah. Great example.
Yeah, right. Good question.
Okay.
Any others?
Thank you. I think that's all we have.